very confident in the ability of this person to teach. And then second of all, you got to filter at the Board of Dentistry because they will review and then issue the teaching license. Again, this is just for teaching license. I'm going to hush up and ask the Dean to come up and speak. Is that okay, Mr. Chairman?
Mr. Chairman, you have one question, it looks like. Representative Mitchell?
Well, I was going to wrap up, but go ahead.
I can reserve my question until after the Dean speaks.
She may answer your question.
Right, there you go. Thank you.
Sounds good.
Thank you, Mr. Chairman.
Dean Young, thank you for being here with us and taking the time to come from Augusta.
Thank you. Thank you, Representatives, for having me here and being able to just kind of explain what this is going to mean for dental education in the state of Georgia. So the House Bill 322 would allow the Dental College of Georgia the ability to increase options for hiring faculty to educate and train the next generation of dentists for the state of Georgia. The bill allows options, or better options at least, for those trained outside of the United States to work as clinical faculty. This is covering students in a clinical setting. Considering the competition with private practice and the limits on faculty pay, it creates an additional recruitment tool for us. Currently, other states allow dentists and dental schools this option. So this gives those schools and states an advantage in providing clinical coverage from highly trained individuals in educating their students. This will provide an additional opportunity for faculty recruitment where we need it. We desperately need it.
Thank you for that presentation. Do we have any questions for Young? All right. Chair Lady Cooper.
Okay. Hey, Dean.
Hi.
It's nice to see you. I don't think we've officially met, but I seem to work a lot with the dental school. When you're saying clinical settings, are you saying they're not going to be the classroom lecturers? They're going to just be in different, observing what they're doing in a dental chair, working with students?
They'll do both.
Okay. Okay. I don't think there's. Are they board certified or anything from other states? Or are we just for information? I'm not trying to give you a hard time.
No. So
are we? I mean, because I know the medical schools have brought people in like this from other countries who have been the leading people in their areas. Like we had one come in ophthalmology from Switzerland, but he was boarded over there and all the things like that. Are there any stipulation on that kind of background for these?
So dentistry and medicine are completely different.
Good.
There's a lot of similarities, but they are completely different. Medical schools have to do, or medical students, when they graduate, they have to do a residency program. Our students do not. They receive their education in 4 years. In medicine, they train in didactics for 2 years, and then they're sent off to the hospital or to different practices. Okay. And they have to usually do whatever their specialty is, board certification in. Our students are competent once they graduate from dental school after 4 years. Now, some do, residency programs. So that's what these individuals, some of them have specialties they've done, but most of them are general dentists.
In the foreign country.
Correct.
How do we know that they were taught? I mean, I know I've been in some foreign countries, and I know you're not going to take me, where it looks like there's been no dentistry, or if it was really bad. How do we know that they're teaching the same dental procedures done in the same way as our highly educated dentists?
That's where we would vet them. And I'll be honest with you, there's other dental schools in the United States that their criteria has decreased dramatically. We even have some dental schools in the United States that only practice on mannequins. That is not our school. Our school has extremely high standards.
Right.
Our students are known for the quality throughout the United States. And we even vet our U.S. trained dentists when they come in.
Okay.
So yeah.
So you would be vetting them and know about the school background and.
Absolutely.
Okay.
Yes.
But it's not specified in the bill that, specifically any background checks about the schools or anything. where they went? No. Okay, it's open up to the people.
But it's upon recommendation by the dean. And I've known this lady for 20 years. She's not going to recommend somebody. Okay.
I'm not questioning, but what about the next one we get and they pull somebody in? Okay, I'm just asking. Okay, thank you,
Well,
Dean. What?
Nothing.
And you're not worrying on anything.
I will say, as I've said in here, other states are already allowing some of this, and they have a big advantage. University of Penn, we had a candidate that really wanted to come here who was extremely qualified. They went to Penn because they could not get a clinical license here, or faculty license here. Yeah.
Thank you for that. Representative Mitchell, you ready now?
Dr. Young, as I understand from earlier testimony, it's difficult to contract or engage dentists. What will be the difference in Savannah?
That's a great question. We are going to need to make some changes in order. Right now, we went from 70% faculty to 80% faculty hires to where we have 80% of our faculty in the last 7 months. A lot of that was changing the culture of the school and the mindset, which has been great. That will only go so far. As I say, we're competing with private practice and faculty salaries are low. So, I think this is an option for us to be able to increase the faculty.
Thank you, Mr. Chairman.
Thank you. Chairman Newton.
Thank you, Mr. Chairman. I appreciate you being here from Augusta. I've enjoyed visiting the dental college and seeing the hands-on teaching that you're describing. I know there's a lab that is training them how to do, that's not on actual patients, it's on like fillings and crowns and different things. Is that where these people would be treating, or they would also be doing that as well as hands-on real patients in the clinic, right?
Both.
Okay, but I do see that y'all have a pretty strict, both those, you got the oversight, they can only do this, it's very clear, it looks like that they can't practice dentistry outside of that situation in Georgia, where they wouldn't be under the guidance and the oversight of you as the dean, plus the other faculty that are there. Is that correct?
Yes, that is correct.
I appreciate y'all having those guardrails in there, because I think that's important for people to know. And you guys, as you mentioned, y'all combine dental school and residency all in well, 4 years still, but
yes.
It's an intensive 4 years, I know, but I know how badly you need faculty, and if we're going to get the dentists we need, you're going to have to do it in Savannah as well.
Yes,
I look forward to that.
What we really hurt with right now is clinical faculty, to being able to cover in the clinics. We have a lot of where the faculty who teach you in the simulation lab, teach the students, we take that over into the clinic, so that what they've been taught in the simulation is taught in the clinic. And that's where, but if we have not enough clinical faculty, we can't take them into the clinic. And so then we might become a school that's only working on mannequins, which is not what we want. We want them to have that real patient experience. I'm sure all of you who go to the dentist would much rather have your dentist have practiced on somebody else before they come to you, instead of just a mannequin.
Thank you. One other question. So they will always be in this situation,
Yes.
only working under the guidance and the oversight. Is the only time they'll be working on live patients, if you will.
That is correct. A faculty license by the Georgia Board of Dentistry, a faculty license only means that they can practice within the dental school. We already have a faculty license, so that they can only practice within the dental school.
Well, I know on appropriations, by the way, this isn't the sole answer, I don't think, is it? We might still have to look at those dental faculty salaries in the future.
I will not tell you no.
Well, I want them to be trained. I appreciate your work.
Thank you.
Representative Jackson.
Thank you, Mr. Chairman. And Dean, thank you too. We visited the dental school this summer with Chairman Hawkins. Enjoyed visiting. And I think Dr. Newton has answered my question. The question was, can they practice dentistry? Can they set up practice themselves besides teaching at the college?
No.
They will not be able to do that.
They do not have an unrestricted license. Only an unrestricted license allows you to practice outside of an educational setting in the state of Georgia. Now, they can practice in Augusta, in the dental school, and they will be able to practice in Savannah because that is the Dental College of Georgia expansion. So that's us.
My next question is, have you taught Dr. Haverson in coming to practice or coming to teach yet?
I talk to everybody about coming to teach.
Thank you.
All right, Chair Lady Cooper.
Thank you. I'm trying to be difficult. Are you saying that even American-trained dentists who teach in the dental school only get a faculty license?
No, ma'am.
Okay, they
Well,
get a regular license.
It depends. It depends on the state that or where they went to dental school and their license there. Now, say that you practice, or you were in South Carolina. We have some that came from South Carolina. If they don't petition to have a Georgia license, then they only have a faculty license. But I have some that came from South Carolina that went ahead and petitioned to get a Georgia license, and so they did. So they have an unrestricted license.
Okay, and with that, since there's a problem with the salary discrepancy, I mean, one of the ways that I think that other schools have solved this would be allowing the dentists that teach also maybe 1 day a week or 2 days, within the schools being first on what their time could, relieve a dentist in the community so they, could take a vacation or if they're sick. And then they would have extra income. Why is this? Wouldn't that be one way to sort of help with?
So we have a faculty practice within the school, and that is an option for them to work in the faculty practice. It's about 20% of their effort, which is 1 day a week, because we need them. We have 96 to 97 students per class. We're increasing that in our school to about 110. That's a lot of clinic coverage.
Right.
That's a lot of bodies that we need in there to do it, because when you're a sophomore or a junior working on a patient for the first time in your life, you don't want to have the faculty covering 8 or 10 people at a time.
No.
but we do have
I realize that. Having run a school of nursing, I understand.
Yeah, but we do have that. They can practice within the school, which is where a lot of our revenue is generated to help us run the school.
So and they get paid extra for that?
They do.
Okay, but it's only within the school.
It's only within the school.
Okay, well, why would we not allow, if these people coming in from other states are good enough to teach our students, why could we not supplement their income also why do they have to have a restricted license?
They have to apply for it with the Georgia board.
Pardon?
They have to apply for that at the Georgia board.
For a restricted license.
Well, they're only restricted to the school, but they still can practice. We have a faculty practice that they go down and they can practice in.
Even with the restricted license, just the school?
Yes, ma'am. Mm-hmm.
Okay, because it sounded like you weren't going to let them.
No. They can practice
work
there.
at least there to get the extra income to
Oh, yeah.
help us keep, if they're good, to help us keep them.
Oh, we do everything we can to make it as.
Oh, that's what I was trying to get
Yeah.
at, but it sounded like
Yeah.
we wouldn't, that they couldn't do that.
No, they
to
can't.
supplement their income. Okay.
But they can
Thank you
they can
very
only,
much.
if a faculty license, they can only practice within the school.
Okay.
They can cover clinic, they can go to faculty practice.
Okay.
Only within the school.
Well, then the only restriction would be, are there enough, is there enough need in the school's special clinic that any of the faculty members that want to have extra money have a chance to work there?
Yes, ma'am.
Thank you. So I would, because
Absolutely.
otherwise, that would be restrictive to whoever, okay.
Yeah, that's our revenue. That's one of the areas we generate a lot of revenue. I want them to practice down there.
Okay, because y'all get a certain percentage of,
We do. It helps fund the school.
okay.
Sounds like a
No,
great
that-
model to me.
Uh-huh.
Sounds like a great model to me.
Well, it does, as long as they have enough patients coming to them at the school and in those 2 locations that they can keep any dentist teaching there that wants to work and earn extra money, that there's enough people for them to see.
We'll tell our friends in the Augusta and Savannah
I was
area.
going to say they should have the best teeth going.
That's right.
So I
Thank-
just would like to say, too, we had over 1,300 applications this year for dental school at the Dental College of Georgia.
Right.
And we do take 10% out of state, but we try to take the ones that are going to stay in the state of Georgia, and at least a minimum of 85% of our students stay in this state to practice.
Great, thank you. Representative Clark, you gonna wave? All right. Chair Lady Silcox.
Appropriate time, I'd like to make a motion.
All right, noted. I will give the dean and the chairman an opportunity to have a closing word, and then we'll come back to you. All right. Dean, you have anything else you want to add?
So I just need to let you know that the application pool for our students, or our student body, is very high. Our GPA, our average is about 3.8. Our DAT scores run in the high 20s. It is very competitive to get into our school, and I just want to assure all of you that our standards are extremely high, and they will not go down. We produce some of the best dentists, I think, in the United States. And I'm very proud of our classes. I'm very proud of our students. So I just want to make sure we're able to maintain that education.
And we're proud of the work y'all are doing, and certainly keeping our mouse taken care of here in Georgia.
Thank you.
Chairman Hawkins, you want to close us out?
Yeah, thank you. We've got eyes to the future in healthcare in every direction. One of the issues that the dental school and the new dental school will be facing is that faculty to student ratio. For them to be accredited by the American Dental Association, and we want our schools accredited, especially Augusta, which is one of the finest dental schools in the United States, they cannot afford to lose their accreditation because they don't have enough faculty in the clinic. Clinical faculty is very important. And Dean Young, Nancy I've known for 20 plus years. She's doing a wonderful job down there. I mean, we were so happy to get her down there, and Chancellor Perdue was right there among us. But not to take your job away, but you do have someone that wants to, and you hadn't seen this because it's left down here. Dave Pratt wants to make a comment.
All right, Dave, come on up to the witness stand over here.
Thank you, Chairman.
I'll be brief. Dave Pratt speaking on behalf of the Georgia School of Orthodontics. Thank you, Chairman. Thank you, members, for your attention to this matter. Thank you, Dr. Hawkins, for bringing this to your attention. We fully support this measure, and we encourage your support. Thank you.
Thank you so much. I think you're about to get it. Chair Lady Silcox, recognize you for a motion.
Thank you, Mr. Chairman. I'd make a motion to pass.
All right, we have a motion to pass. Do we have a second? All right, we have multiple seconds. All right, any discussion? All right, seeing no discussion, the bill before us, we have a motion to pass on the committee substitute to House Bill 322, LC 461130S. All in favor, make it be known by saying aye. Aye. All opposed, like sign. Unanimous. Mr. Chairman, you got your bill out of your committee.
Thank you, Representative Kelly. And also I want to thank the Dean of the Dental School and those folks here from Augusta for bringing this bill and taking the time to be here. I know you're very busy. Thank you very much. Okay, let's do the next bill. And how about Representative Dickey, HB 227. We'll be working off LC 550517S. Oh, okay. Yeah, that's
It gets a
fine.
little,
that's fine. You stay over
that chair gets a little warm over there. I thought I'd come over here with a little
there. I
more
thought you'd
room.
left. I was going, where is he?
Well, thank you for having me back in the committee. And our meeting last week, I appreciate the inputs and the suggestions. But, you know, as I was driving back down I-75 to Macon to Musella, you know, I kept thinking about the things I want to do in this bill, and it's only 3 things I want to do. But I really wanted to put the patients first, and I just wanted to get back to make sure this bill put patients first. And I don't think in all our wisdom and all our efforts up here over the last few years, I think patients have gotten kind of pushed to the side, and we've got everything in place. Except a few minor adjustments. I think this bill would help put the patients first and make them aware of this products. And I just sort of got back to the basics of this bill. Georgia is by far the lowest state, the lowest number of patients of anywhere in the Southeast with patients using prescribed medical cannabis, and I think this bill would help move that. First, as I said, it changes the name, replaces the term low THC oil with medical cannabis, and that's a change that's long overdue. It was 10 years ago trying to describe what this product was with a low THC, and so the medical cannabis simply aligns it with our Access to Medical Cannabis Commission, who is here, by the way, today, and I want them to speak behind me. A few things. I reached back out to them after our last meeting, and they have been a tremendous help trying to focus this bill. Number two, public awareness to existing patients, subject to the rules and regulations of our existing Medical Cannabis Commission. And then on the last page, taking away severe and end-stage conditions. No other states in the country or around us have severe end-stage. It's up to the doctors. Doctors has to prescribe this medicine. And so I just go back to trusting doctors with this and trusting the product. This product is produced right here in our state under supervised conditions, tested, dispensary. It's got all the handcuffs on it with this legislature could put on it, and so that's really all this bill does. We did add lupus. Representative Schofield has some suggestions there, and so that's the bill that I bring to you today, the sub. And I'd like to ask Andrew Tunage, who heads up our Access to Medical Cannabis Commission, to come speak a few words, and his counsel, Jansen Head. You can do there or here.
I hear it's warm on this side of the room, so I'll take an empty seat, and I'll ask our General Counsel Jansen Head if you want to come up to the table in case I need to grab your elbow. Thank you, Chairman Dickey, and thank you to Chair Hawkins and this committee for the opportunity to come and speak to this bill. I'm Andrew Turnage. I'm the Executive Director for the State of Georgia's Access to Medical Cannabis Commission, and it is the Commission's responsibility for oversight of the growth, production, manufacturing, transportation, and dispensing of medical cannabis products in this state. We certainly have very much appreciated the opportunity and the invitation from Representative Chair Dickey to look at the bill. We've given it a thorough comb over, and we don't find anything that gives us heartburn whatsoever in the language of the bill. It's very much within the purview of the work that we do each and every day at the Cannabis Commission. I think it's aligned with the purpose of the HOPE Act and the work that we do with our staff and our appointees at the Commission as well. The items, Chair Dickey did a perfect walkthrough, really took all of my talking points right out of my hands. It's exactly what I would have said. I think you can see the references in the bill on the items that Chair Dickey referenced. In line 21, you can see that there are adjustments there making the change from low THC oil to medical cannabis. That's what everyone knows the program by, but that language is just simply residual language from days before the creation of the commission. So I think that is a great cleanup. I think that awareness about this program is very important. Looking over at the language that you see with 241, line 241, this is work that we do, and it makes it really clear for those who rely on Georgia code to figure out who is the authority and what is the accurate source for information. It's important for people to know that they can come to this state agency and that this is the home to get the correct information about the licensees, about the products, and about the program. And I think that language makes it clear for some work that we've already been working very hard to do with our partners in state and local government, both at the county and the city level, about the program. As it relates to lines 269, it's really important for patients to get accurate information. I'm sure that all of you in the healthcare fields that are respective to your credentials and your work know that there's a lot of misinformation that people access. People rely on the internet, for example, as a source to find accurate information. We think it's important for patients to be able to get accurate information that provides an avenue for patients to get exactly that from those who are involved in this program. And last but not least, on the conditions, you can see some of the changes that start on 318. One of the things that Representative Dickey already touched on is that we do rely on physicians. This is a medical market. It is a medical program, and we certainly put our trust in the physicians as they certify those patients for their needs. So that's everything that I can think of, unless our General Counsel Jansen Head or Representative Dickey, if you'd like to add anything to that. We appreciate the opportunity very much to speak today.
I have a couple lights with questions. Representative Cooper, is that you? Okay, go ahead.
Thank you very much, Mr. Chairman. Okay, the first question I have, when you talk about awareness, several of us on this committee had questions about the awareness last time. Do you see that as running ads on television?
I think the language that's here makes it really clear that the commission can put the guardrails that are in place that are appropriate for the program. We've done similar things already with packaging and labeling. That language is already in the HOPE Act, for example. Things that make it really clear who can make the purchase, that it can't be appealing to children, that it's products that can only be sold in specific locations. Those are all programmatic pieces of information that we require of licensees, and I certainly see this as falling right in line with that.
Okay, but you're saying you could pay for television ads?
I'm saying that the language that's as written might allow for that, but you can see that the language in the bill would say that it's going to be subject to the requirements of the commission.
Okay, and Mr. Chairman, if how would you pay for those? Is there anything in the previous bills that would allow you to take grants, money from maybe the companies that produce this? I'm just curious about how you would finance it.
Mm-hmm. And just to clarify,
do you have the ability to take grants?
And just to clarify, Chair Cooper, when you say you pay for this, do you mean the commission pay for this?
Yes, of course.
Okay. So, again, the General Assembly is obviously the place where I come and present the commission's budget. And so the only information that we're going to be able to purchase with state tax funding is what this General Assembly approves for the agency. So I don't know if you'd like to add to that.
Yeah, if I could also respond. Again, I'm Jansen Head. I'm the Commission's General Counsel. Thank you for letting us speak. So we were here in the last committee meeting, and we heard concerns about TV ads, adding conditions. I think the purpose of that part of the bill, the substitute, was more so making sure that patients who have a card just know where to go. They go to gas stations, they go anywhere and think, well, it's got a marijuana lease, like I guess that's a regulated product, and it's not. We get calls all the time, where do I go? Currently, companies cannot advertise, so it's kind of like word of mouth. It's like the legal black market, where it's like, hey, you got your card, we can't talk about it, but if you go to Chamblee, you can get product there. And it's tough to tell patients, hey, go here for products that the state regulates. Now, with the concerns of TV ads, the difference between the original bill and the substitute is it puts authority with the commission to promulgate rules to ensure that any public information, well, not public, one, you can't advertise to the public, but you can advertise or share information to just the physicians, just their caregivers, and just the patients with a card. So there's no public advertising allowed. So TV ads, not allowed. Anything to the public would not be allowed. And funding for that would be on the licensees. We definitely don't have money for that, but the licensees would have to pay for that.
Okay, yeah, go ahead.
And this bill gives the commission the authority to regulate that information,
Right.
how it's presented. and
Okay,
given.
the main thing, all right, let me make clear, understand, because this is a concern of mine. Because you started off, we only have 1,000 patients and somebody else has 100,000 patients. I mean, I would, so we don't have to keep up with other states. And so right now, are you saying that you could give companies the ability to advertise, but it would only be to patients and so forth?
I think the issue here is just not knowing what advertise can mean. I think what the wording does in the substitute says, hey, the licensees can educate patients on what the products are. That's the real issue. So what this bill does is it gives the commission to promulgate rules, meaning we propose rules, and often we ask committees for input. We notify the committees, hey, we want to promulgate rules, let us know if you object, have feedback. And then a lot of times we get a lot of feedback from patients, from people who like the program, who don't like the program, parents, elected officials, and we are subject to the Admin Procedure Act, so we have to have public hearings, public comments. So all of our rules we have in place now that regulate packaging, labeling, how you design your store, how you design your packaging. If we had demos, not samples, but demonstrations of the packaging, it just looks like some kind of topical product. It doesn't have cartoons. It's not targeted to attract people. So how we regulate what the products look like or stores, it'd be the same way to regulate any kind of sharing of information. And the numbers, I agree, we shouldn't always compare to states, but I think that data that Chairman Dickey shared was more so not about advertising, but about the conditions, about how, because we require conditions to be severe and end stage, and we talked about that last week. Yes, he was just sharing that show, like it is kind of hard to get a card here when you have to have severe end stage cancer and things that pretty much every medical state doesn't require to be severe end stage.
Representative Newton. Oh, I'm sorry, I thought you were through.
I hear your concerns, but I think we've got a great commission here that's been in place, got a group here that has got a track record of conservative pathway for this drugs, and I just trust that I think they will in the ensuing year or two or whatever this committee can always come back with legislation to change it. But I just think it's time to give somebody some pathway to give information to the patients.
Okay, thank you. I'm sorry, I am not trying to be difficult, and Chairman Dickey, I'm not trying to do anything, but before we had the meeting last week, I'm very concerned about patients, and that they just think this is the panacea, that they reject going for medical care, and when it advertises, I just had problems with it, and I've had from the beginning. And they started with the very first hearing we ever had, and there was a father in the room who had a 10-day-old in intensive care with seizures, and he wanted that baby to have, before it had any medical care, before they tried any other way to stop the seizures, he wanted that baby to have marijuana, and that, this kind of thing. And so this comes from, and as I walked down the hall last week before they had this meeting, this is where this concern is coming from. I had a lobbyist tell me that basically this bill is because we allowed several companies to produce this drug, that they have invested in the state and they are producing so much that there's nobody to buy it. And so therefore, it is not profitable to their company. Do you understand what I'm getting at? So they are looking at ways to just really push it to make money. And when we first passed this bill, and when it finally passed, it was the consensus of many of us that we never wanted to go down the road to having legalization of marijuana in our state. And so all of them, we've got a company producing. One company right now is producing enough for everybody in this state to be on it. And we have 3 companies. So they've invested in the state, they're producing it, and they don't have enough customers. And so my fear was this was the first step. This is my fear, but I know a lot about healthcare and about patients. And that is why I'm questioning. I'm not trying to give you a hard time, and I know, Chairman Dickey, that you would not do anything to intentionally hurt patients, but that's my fear.
Well, I can't allow your fears. I mean, that's been the case for 10 years, ever since Alan Peake first brought this, and that's why we got physicians prescribing this product. You got to get a physician engaging with the patient to know whether this product would be appropriate, whether it would. I mean,
it's
for
not
the
about
patient. So, that's my fallback is instead of the patient going out to the smoke shop in the shopping center looking for products that hadn't been tested, don't know what the heck they are, let them know to go to a physician and get this prescribed if this product is appropriate for them. Is my whole point of this.
Chairman,
now, I don't know anything about the companies. This bill doesn't have anything to do with all the with all the licensees. It doesn't even go there. So it's just about the conditions and the patient and the name of the thing. So
not when
Representative Cooper, let me interrupt. I'm sorry. I've got a lot of lights.
Go ahead.
Thank you. Okay, Representative Newton.
Chairman Dickey, and I do appreciate the changes you guys have made on this. I think you did address a lot of my same concerns that Chairman Cooper has mentioned, which is advertising the public, trying to appear that you're trying to grow the program, if you will, because there are, quote, not enough people, and you got all these suppliers. A couple of things, just specific points on line 242. This is the part, there's 2 different kind of public awareness things. There's what the commission can do, which you said is obviously limited by what we appropriate for the commission. I have a little question with the word effective, because if you flip over again, over on the next page is what the licensees can do. It says they can't do something that's unsupported by reliable scientific evidence. The challenge I have is, other than intractable seizures and a little bit of chemotherapy nausea, there really is, I mean, it's a Schedule I product. Nobody's studied it in any NIH receiving facility, so there is no, there's not a lot of evidence. And so I don't know how you say we're not going to let anything out there that talks about the effective uses. I would rather that effective over here on the commission itself. I would rather them have to have things that was supported by reliable scientific studies. I do, however, appreciate when you took advertising to the public and you narrowed it to the physicians, well, it was already to physicians, you narrowed it to registered patients and their caregivers. To me, you dramatically narrowed and put guardrails up on this bill that make it allayed many of my concerns that it was going to be a growth industry effort, economic development, if you will, and it was going to be out there listing to patients, going on social media to my kids and grandkids that hey, if you got sickle cell, or if you got lupus, or if you got pain or PTSD possibly, we can get you some medical cannabis to try. I'm glad you narrowed it significantly. I think you made it much. You're down to 20,000 people in Georgia instead of 11 million.
Yeah.
And I think this has very little. I hope there's going to be minimal advertising, because reliable scientific evidence is just not out there.
Yeah.
And I hope that the commission has a high standard both for their own use of this effective word, and also for the not supported by, or is supported by reliable scientific evidence. I appreciate you doing that.
Would you go? Could council say one more comment, I think?
Thank you, Mr. Chairman. On the word effective, I think, so right now, the commission already does some outreach, but on our own initiative. We're technically not required to educate about the program, but we feel so strongly to educate these patients on where to go legally that we took it upon ourselves without asking for funds. And we just did it. We were tired of hearing calls from patients just confused, and then we got confused, and 20,000 may not seem like a lot, but those are lives. We want to help people. So what we are doing now is we're educating about the program. We think it's important that that's a duty in the law. Whether we're still here, new commission members, that needs to happen no matter what. And that helps keep it as a medical program. On the effective part, I think that looks more so into the future. The HOPE Act looks at universities like UGA, Fort Valley to do research. And once they kind of enter that space, and there are some discussions, once they enter that space on research, then we can partner with them to talk about their studies on how it may be effective. So I think that language is more so future forward looking, and that's to help us partner with USG and TCSD institutions.
If you don't mind. All right. Since you brought that up, just one quick thing, and you made a great point about this is to patients and their caregivers and physicians. Would you be willing to limit the Cannabis Commission's public awareness to that same group you just described, which is helping people who already have a card, not looking like you're trying to go expand the universe of people with a card. You describe a very real problem, and if there was a way to limit this public awareness to where it really wasn't to the general public, it's really to the people who need to know, and it's not a way to advertise and grow the program. It's just to inform and to solve those problems you perfectly well mentioned.
So I will say that we are already kind of conservative in our approach. We don't have ads. We're not doing mass advertising about the program. I'm going to respectfully say no, because it's going to take away what we're doing now. So we actually teach a post-certified course to law enforcement, and we have partnered with different local and state groups to tell law enforcement, hey, if someone has a card, these are products that they can have on them. Anything else, that's not legal. We also educate attorneys, so public defenders, DA, so that if someone is seen with something or they have this insane amount of marijuana, when they call us or look at our class and it's certified, you get credits for this, for their law license, for their post credits. They get credit for that. And we're actually, we're in communications right now with the medical board to also look at maybe creating some kind of CME to educate physicians on how to best treat their patients and what that treatment plan should look like. We also partner with GMA and ACCG to educate local government about the stores. There's some zoning concerns involved. So if we limit it to just patients with cards, we would pretty much take away 80% of our outreach now.
Okay. Representative Silcox.
Yeah, Mr. Chairman, I just wanted to say that I do have a friend currently that has cancer that has been taking medical cannabis, and it's been very effective to relieve their nausea, and I appreciate that. I would like to see y'all asking for research dollars for the University of Georgia and Fort Valley, because I really do think it would be great. The greatest thing you could do for your product is to get that scientific evidence that all of these conditions, not just seizures and chemotherapy, that they really are effective on all those levels, because I think that's really important to have the proof.
Thank you for sharing that. And we are talking with those institutions. We can't share too much, but we are talking with them.
I know that marijuana is still Schedule 1 drug, right? And so that's the prohibition now on the research.
Yeah, some individuals are at least interested, and
Okay.
some are looking for ways to still do state funded research
Okay.
to not implicate some of those federal concerns.
And I guess I was hoping that because this is medical cannabis and not straight marijuana, that maybe y'all could get under the wire.
Yeah, federal government has no regard to medical use. I mean, that's just that issue. They're going
Okay.
through stuff now, but we are talking with those institutions, and there is interest. It's just
Great.
going through to make sure that they're protected.
Thank you so much.
Yes, ma'am.
Representative Douglas.
Thank you, Mr. Chair. I've listened to the other committee when you just came in. It was just a hearing only, and you have corrected and amended this bill, your bill, to all of the things that wanted to be added or omitted in your bill. So I think when you give people license, this is any business, and you don't give them the tools to get better at their job, then we have a serious problem. And we're lawmakers. If it doesn't work, we can come back next year and change it. But give them the necessary tools to further along the study of what they've done in our state to make it amenable. Because everybody is hurting in some way. And for the most vulnerable, the word speaks about the people that's among us that's the most vulnerable, that need help. And we have the ability to give help, and we don't want to do it. And so until you're affected personally, somebody in your family needs it, then you want to make a change. That's right. So let's do it now. So, Mr. Chairman, at the appropriate time, I'd like to make a motion.
Yeah, we got a few more questions.
Okay.
Some folks to speak. Thank you, though.
Yes, sir.
Who do we have now? Representative Davis, you three. Yeah, you're
Thank
three.
you, Chairman.
Yeah.
My father is a Vietnam vet and has PTSD. And I didn't really realize how much of a problem we have until he came to me and he said, I don't know where to go to get any type of medication or the different oils that he wants. I mean, he didn't have a clue. And he said, well, you're up there at that Capitol. Why don't you tell me? And I'm like I know. I mean, really. And then when you go to the corner gas stations, I mean, they selling everything. And you don't know what is legal, what is not legal. So if there's some way to bring this into where there's some order, where people know what they're buying, let's start there. And it at least put us on the right track where the people who need this can have access to it and know that it's regulated and it's something that they can trust. I look forward, and I'm glad you did this bill.
Thank you. Representative Clark.
Thank you, Chairman. We'll say, since we passed back in 2015, I've got so many emails, calls, people going, okay, I have my card. How do I get it? What do I do? So confused. And I'm like, I'm not sure, like, go call the committee. I mean, I'm even a little bit confused. And I think we have a long way to go because if we passed the bill, we fought so hard over this. I remember those days during session, I was back and forth, and it was like a slugfest because of the stigma. But definitely, acknowledging and helping the patients understand how to get it, and even helping the doctors and law enforcement, all understand the rules, the law is a huge thing. So thank y'all. And definitely with the PTSD, I have so many buddies who have used the medical cannabis. They've gone to VA, used other drugs, and I'm not anti other drugs. I'm not anti taking other things. It's what your physician and you sitting down talking about that, but I know how many have been helped. And just one, I won't say his name, he's runs a big nonprofit, but here in Georgia, but he was taking all these drugs from the VA. I mean, his life was spiraling out of control, and then he went and used medical cannabis, and an amazing man, touching tens of thousands of lives, but he uses the medical cannabis, and it changed his life and his family, his wife, his kids. So I'm thankful for that. And Robert Dickey, Chairman, great bill. Love it.
Thank you. I just want to make one comment, then we have a few people on speak to it. We seem to keep going around this tree about the advertising. It is in code now on line 266, no licensee shall advertise or market, and what was struck was low THC and replaced by medical cannabis. So we already have that in code. What it's also added to the information part is registered patients and caregivers.
Right.
So I think you've got this very tight, and I appreciate your
Trying my
work
best.
in listening to some of my colleagues and their concerns. Okay?
Thank you.
Thank you. Okay, now let's hear from the audience, and I would ask you to be brief with your comments. We have more legislation to come, and these people are here to get their legislation through also. Is it Aviva? Okay, go ahead.
Thank you so much. My name is Aviva, and I have a friend here today, but we're going to keep it serious, so he's not going to do that much talking. This is a serious issue. I'm not sure exactly where to start because there's so much here. Why are you looking at me? You said I can't talk. Sorry, Scribbles. I just think that I have a background in child studies. I went to Tufts University and got my degree there. It's pre-med. And so I'm really into studying the psychology of situations and trauma responses. And I think that we've been all under this trauma of having this illegalization in the first place. And I'm really grateful to Chairman Dickey and everyone who's having this conversation so we can bring healing for the patients first, right? And I understand all of your concerns as a brother who works in the emergency room and whatnot. I have a brother. But I do think with any kind of suppression, when we've taken something away from people, it's very hard to put it back together, like Humpty Dumpty. And so, though we think we're helping people and also industries by having these cards, I think one of the reasons why I think the program is unsuccessful is that it is kind of a pretty big ask for people to pay for a card. The insurance doesn't cover the medication. There's no other I think it covers all other medication. And then, of course, the big out of balance thing is that it's illegal at all. Like the fact that we're bringing this illegal substance here as medicine is very confusing for people. And that's why it almost makes more sense to legalize it first. I'm not going to say much more about that, but that's what is bringing disharmony to the issue, because I know people who don't even want to try medical cannabis because it's illegal. They don't want to be stigmatized. They don't want to be judged. And they're scared they're going to get arrested. Also, because it's not legal, we can't research it. You know, those were some really good points. We need research, but we can't really until it's free for the people. Also, you have to give up your rights to bear arms to have the medical cannabis, and this is a bipartisan issue. You know, some Republicans use as well. And the biggest thing that I notice that's different from Georgia medical cannabis and all others, and you're right, we don't have to have more people, but we want to help the people. And the people in all the other medical cannabis programs are getting helped with the flower. We don't have flower, and we can't, and the caregivers can't grow their own plants. If you look at all the bills, like I printed out the Arkansas bill so you can look at it, caregivers can grow up to 7 of their own plants. Now, this might sound scary and more smelly, but the thing is when you grow your own, you can actually manage the quality of it, because there are some pesticides used. Some of the oils that are great, you know, with the cannabis, they do have neotame and other substances. In Georgia, that might be the only thing people can get, which is like aspartame. Some people who use diet for healing, which might have, you know, exited out of the medical system a little bit, but not completely, they don't do the seed oils that the hemp oil is made of. They have a very restricted diet, so they need the pure plant. And then that's pretty much it that I wanted to say. Scribbles might have some closing words, but I do want to say that it's not a big ask, because I know this was brought up, for them to not smoke in public places. You can put that in the bill. There's been complaints about the smell. Just if flower is in the bill, then you can say, don't smoke in public places. It's not allowed, or you'll have penal. There's no reason why anyone has to put up with that smell. You know, there's no reason why someone should feel engulfed by it. It's not a good feeling.
So yeah, I have just some closing words to say that all medical doctors take the Hippocratic Oath, and I think Hippocrates might be rolling over in his grave because he said do no harm. And it's kind of harmful to just have so much confusion, and we need more clarity. We need to move forward with this bill. And also, he said, well, some people say he said food is medicine and medicine is our food, and that's really important. What we eat, where we live, and the habits we have. And yes, some people have bad habits with weed.
That's true. And some people have bad habits with sugar. That's also true. So what's needed? Education, and let the doctor decide if their patient has a problem with weed, they might need something else and not medical cannabis. We got to trust our doctors. That's a very good point.
Okay, thank you very much,
Thank
both
you.
of you. Okay, Scotty Allison.
Absolutely. I'll try to keep it brief. This is actually my first hearing and my first time down to the Capitol to speak in front of all y'all. I've been in the cannabis industry for about 20 years now. I graduated at the Oaksterdam University College in Oakland, California, which is the United States' first medical cannabis college that has been federally recognized by the federal government. I graduated with valedictorian honors. And I would just like to say, as far as 227 goes, what is this going to do to the hemp industry? Like everybody that's already producing or already buying hemp products at locations and all of these mom and pop shops and all these retailers that have already opened up, what is this bill going to specifically do to those industries? Because right now they're selling gummies that have 10 milligrams of THC in it. They're selling gummies that have CBD in it. It's already legal federally. So what are we sitting here talking about, like patient cards and medical, I'm sorry, I'm a bit nervous, but I don't understand why we're talking about patient medical cards and whatnot when we should just open it up full plant, whole plant legalization across the board. This really seems like more of a corporate takeover to me more than anything, with having to go and process cards. People that can't potentially get a card because they don't have the right illness aren't going to be able to get access to the plant. I'm sorry, again, I'm a bit nervous, but I do have more knowledge and more credibility in this industry than anybody sitting here and almost any doctor. I would say even doctors need more education, because if you ask doctors what the endocannabinoid system is, they have no clue. So that's where I'll end it.
Thank you for your comments.
Absolutely.
David Radabaugh, is that right? David Radabaugh, are you here?
I think he's in another meeting.
You think he left? Okay. Well, that's all the folks to speak on the bill. Do I hear a motion? Motion to pass. Second. Second. All those in favor say aye. Aye. All those opposed? Congratulations, Chairman Dickey. You have your bill, and that bill number is LC 550517S. Okay, up next, Representative Richardson with HB 154.
I'm from California to study at Oaksterdam University, and I was there for Here, I'll give you my, I made a bunch of copies of my cert. See if any,
Urban Laureate.
and I do have my union number, still very nervous. It's my first time up there talking.
Did you find your
I actually, no, I've got a bunch of different things. I've got a 658.
There's a chair right there. There, you're fine.
Yeah, absolutely.
Sorry. We're just gonna
No, you're
turn it
fine,
on you.
please.
Is it the right LC?
Yes, it is.
Thank you.
Text me your name.
I showed her to it right here. I'm gonna call. Hi. Just tell us. It's super short. 2 seconds.
Go ahead, Representative
All right,
Richardson.
All right, Mr. Chairman, thank you, and committee, thank you for hearing our bill today. This is HB 154, LC 520767S. And what this is to make EMS an essential service. The public undeniably considers EMS to be an essential service. It is directly connected to the 911 system and is mandated by the state to provide pre-hospital care. EMS is the third leg of public safety stool, sitting next to the legs of law enforcement and fire services. We need to recognize it is essential because our citizens most certainly do. EMS workers are the only emergency public safety employees of the state that are not considered essential. They regularly work alongside firefighters and law enforcement personnel, both of whom are designated as essential. National Association of EMTs reported that in the past years, the turnover rate for full-time emergency medical technicians reached as high as 36%. And for the full-time paramedics, it was 27%. According to an American Ambulance Association survey, nearly all of the EMTs and paramedics who left so did voluntarily. More than 1/3 of new hires don't last through their first year, according to the survey. The designation covers both public and private agencies. There is no intention to create a mandate. This bill should not be seen as support for EMS care, especially during disaster. This bill should be seen as support for EMS care, essentially, especially during disasters. There is no next step. The intent is to simply designate public and private providers of emergency pre-hospital services as essential critical support by the state. This does nothing to address the zoning concerns or anything like this. So,
Okay. I bet Representative Roma would like to say something.
I bet
too.
she would. I bet she would like to
No,
have
you
word.
should.
Thank
because
you.
Let me just tell the audience, Representative Roma had a similar, almost identical bill last year, and it got stuck in the Senate. We had both representatives bringing the bill at this bill, and Representative Richardson happened to have the lowest number. So, out of courtesy to Representative Roma, go ahead.
Thank you. Thank you. You all were kind enough to pass this last year. There have been very minimal changes. And as I had previously said, this bill came about because my husband is a part-time EMT. I had an opportunity to talk to his coworkers, and they were the ones that first alerted me that EMS is non-essential service. And we would be joining 15 other states by designating them as such. And so this is just an important oversight that we agreed on, and sounded like Representative Richardson's folks in his county also agreed. And so now we're here.
Great. Okay. I know you have an amendment, a clarifying amendment to this, right? But first, let's hear, are there any questions? Let me ask that. I don't see any questions. Oh, okay, go ahead.
I appreciate this bill, and obviously anything we can do to help stabilize that industry is crucial, and it's one we all forget about until us or a family member needs it, and then all of a sudden we hope the county or the city or whoever it is has done their job. We especially noticed it in the storm recently with the roads being blocked. The first thing that we got open was at least one lane everywhere, so an ambulance could come to you, and I had neighbors that needed that. Is there something in state OCGA that when it's declared essential, is there some switch that's flipped? I know you say it won't impact any provision on a local entity on whether they have to cover it or not. Essential sounds like you have to cover it.
No, so
that's not the case.
Exactly. So all this does is it actually takes away a lot of red tape that EMS providers have to go through to get similar funding and support that fire and law enforcement go through themselves. And so and we've talked to everybody from legislative council to stakeholders to even people who had concerns about this bill last year, where it was clear that by designating them as essential, there's no other clause in here that forces any sort of funding mechanisms within it either.
And the EMS services back this.
Yes.
They do, and that was the code update that I added to make sure that they were okay. So nothing changing the zone areas or any of that. So that's the couple of numbers that.
Thank you. Thanks for the bill.
Representative Mitchell.
Mr. Chairman, I was going to make a motion and do pass.
Okay.
He's ready to
We got
go.
a motion to do pass. Do I hear a second? Second. Okay, before we vote on that, let's hear your amendment.
It's just adding the code, let's see, the code numbers of,
3111-3 and -4 after the word section and adding an S to sections. This is on line 17.
Line 17.
Okay?
Line 17.
All right. Do I hear a motion on the amendment? Do I hear a second? All those in favor say aye.
Aye.
All right, back to, all those in opposal. Does anybody oppose it? No. Okay. Then back to the main motion. Do I hear, what we've already got that. Let's go ahead and hear the, all those in favor on the amended bill 154 LC 520-767S. All those in favor say aye.
Aye.
All those in disagreement say no. Congratulations, your bill is passed.
Thanks all.
Thank you
Very much.
All right, our next bill up is Representative Hilton, HB 329. And that LC, Representative Hilton here. I can't hear you from
He's
where
on
you
his
are.
way, he
Oh,
said.
okay. All right, well, let's take a few-minute break until Representative Hilton gets here. All right, let's come back to order. Okay, Representative Hilton. Are you good with the seating arrangements now?
Yes, sir.
Can we bring you anything? Okay.
Maybe a bathroom if you got it.
Yeah. We'll just stay low to the table, okay? Go ahead. Thank you.
Thank you, Mr. Chairman, members of the committee. Honored to bring you House Bill 329, reading from LC 461050. You know, my favorite bills are the ones that are brought to us by the 60,000 people we work for, and this happens to be the case with House Bill 329. So I'll most likely let the folks to my right do most of the talking. Susie Snyder is a proud member of House District 48 and came to me in the off session and said, hey, I'm in the field of artificial insemination, and there's certain things that we're not allowed to practice. We're allowed to do so in other states, and Georgia's kind of an outlier in that regard. And I said, this sounds like a great idea. I know this body is very pro-family, pro-life, and a lot of things and actions we take, and this seems to me to fall right in line with all of the pro-family policies that we tend to pass here of making it easier for families who are looking to conceive do so. And so with that, I will actually turn it over to my new friend and constituent here, Susie, and if you'd introduce yourself and your colleague and share a little bit more about the bill for us.
Okay.
Yeah.
Good afternoon, Chairman Hawkins, Vice Chairman Kelly, Representative Hilton, and members of the Health Committee. My name is Susie Schneider. I'm a nurse practitioner for the last 25 years, working in reproductive health. This is Dr. Jang, who's with me today, also a reproductive endocrinologist working at Shady Grove together. Thank you for the opportunity to be here and to discuss House Bill 329, a critical bill that will expand access to fertility care in Georgia. I am here on behalf of nurse practitioners and physician assistants across the state, and with the support of the American Society of Reproductive Medicine, the Georgia Fertility Network, the Georgia Obstetrical and Gynecological Society, the Medical Association of Georgia, and esteemed fertility specialists, as I've already introduced. And we are missing Dr. Stephen Gay, who's worked very hard on this. Together, we strongly urge the passage of HB 329, which will allow advanced practice providers to perform inseminations and remove an overlooked barrier that limits access to care for Georgia families. Artificial insemination is a simple, non-surgical procedure in which a prepared sperm sample is inserted into the uterus at the time of conception, for conception. The process is quick, low risk, and no more invasive than a pap smear. As nurse practitioners and physician assistants, we are not new to intrauterine procedures. Every day, we perform medical procedures safely with the use of uterine catheters. These include saline sonohistograms, histosalpingograms, endometrial biopsies, and IUD insertions. Not only do we have the technical skills to safely perform inseminations, but our physician colleagues support this change. Allowing APPs to do inseminations will free up physicians to focus on more complex fertility cases, maximizing efficiency and improving care for all patients. We propose that HB 329 is a common sense bill for Georgia. Number one, it increases patient access. Georgia families face long waits and scheduling difficulties because inseminations can only be done by physicians. APPs doing inseminations will improve flexibility and reduce these delays. Number two, it contains rising costs for patients. Fertility care is expensive, and unnecessary restrictions only make it harder for families to receive treatment. By expanding provider availability, we can help reduce these financial burdens. And number three, it keeps Georgia competitive. Every other state has recognized that APPs performing inseminations is a safe and effective practice, and Georgia families deserve the same access to care. So in summary, HB 329 is a common sense bill that supports Georgia families. It expands access to fertility care, upholds medical safety, and allows trained APPs to perform a procedure we are already well equipped to handle. It benefits patients, providers, and the broader healthcare system. Georgia should not be the only state holding on to restrictions that limit access to care. So we urge you to vote in favor of HB 329, giving more Georgians the opportunity to build the families they dream of. Thank you.
Thank you. You have anything to add? And I would say this, I know we have one or two that want to speak. If you could keep it short, because I'm losing a quorum. He's not going to be able, we're not going to be able to vote this bill if we
Please keep it short.
Yeah, yeah. There is a question. Representative Kelly or Newton? Okay, Representative Newton.
I appreciate the guardrails you put around this. You made it pretty obvious that that someone's at the location at the same time. I know it's a team approach that we take to a lot of areas of medical care, and you make a great point that this is a rational advance in the team approach of medical care. That doesn't mean you have to be directly within the physical presence, but they've got to be in the building. Is that correct? Whoever's the supervising, and I appreciate the teamwork y'all do on providing us, as Representative Hilton mentioned, reproductive care to in a way we can encourage families to have families, and especially in challenging areas. Thank you.
Would you like to add?
Yes, thank you. My name is Dr. Victoria Jang. I'm a board-certified obstetrician gynecologist. I grew up in Georgia. Glad to be back taking care of our patients here in this proud state. And I am a reproductive endocrinology and infertility subspecialist. I have dedicated my career to be able to help families build throughout their lives and help parents actualize their goals of building their families. I just wanted to add that House Bill 329 is pro-family, it's pro-access, and pro-patient care initiative. And it removes overlooked barriers, preventing APPs like nurse practitioners and physician assistants from being able to perform artificial inseminations, which is a procedure they are already well equipped to be able to perform. They are performing very similar procedures on a daily basis under physician supervision, and we are absolutely going to have physician oversight with a physician at the location. Patients can still have the opportunity to have their IUIs performed by a physician if they would care to. And this is a movement that is being backed by a number of medical organizations that are heavily involved with the OBGYN and fertility care space. We're the only state that is prohibiting APPs from performing insemination, so this is a great movement towards modernizing Georgia to be able to improve access to care for our patients. So thank you so much for having the opportunity to speak today.
Thank you. Thank you. We have a Robin Pingington that wants to speak.
I just wanted to say that I'm Director of Government Relations for UNPRN, United Advanced Practice Register.
Can you come up to the mic? I'm sorry, but...
Thank you. Sorry. Thank you, Chairman. I'll make this very brief. I'm Robin Pinchton, Director of Government Relations for United Advanced Practice Register Nurses of Georgia. We approve and promote any lifting of barriers that restrict our patients in Georgia from getting the care they need. So we like this bill very much. Thank you.
Thank you. Sheila, do you want to say something real quick?
Thank you. I
Yeah.
support it. How about that?
That's quick. Okay. Do I hear a motion? Second. Do I hear a second? All those in favor say aye. Aye. All those opposed? Congratulations, Representative Hilton. You have your bill.
Thank you, Mr. Chairman.
Thank you.
Thank you.
Okay. Thank you to the committee for hanging in here. And we'll meet again next Monday, okay, 2 o'clock. Thank you.